And I said, did I say something to upset you? And she said, you're the first doctor who thinks that there's something physically wrong with me.
Wow.
And it's not all in my head. And I said, I don't know what you have, because I didn't know. I said, I'll certainly be, looking things up. But I said, what I can say to you is you're not normal. There's something really wrong with you. And she burst into tears again.
Hi, I'm Nathalie Sloane, the Executive Director of the Institute for Neuro-Immune Medicine in the Kiran C. Patel College of Osteopathic Medicine at Nova Southeastern University. Thank you for joining us today on the Hope and Help for Fatigue and Chronic Illness podcast. Today, it's with great pleasure that I introduce my guest, Dr. Alison Bested. She is an associate professor, the chair of the Department of Integrative Medicine in the Kiran C. Patel College of Osteopathic Medicine. Dr. Bested, thank you so much for being here today.
It's my pleasure to be here.
Dr. Bested, can you tell us how you found your way to the Institute for Neuro-Immune Medicine?
Yes, it happened because I got to know Nancy when we created the Canadian Clinical Guidelines for Chronic Fatigue Syndrome or myalgic encephalomyelitis, and that was way back in 2002. So it was in the middle of winter, and I'm from Toronto, Ontario, Canada, and I thought, wouldn't it be nice to see what Dr. Klimas is doing these days? So I made arrangements to come down to the INIM clinic as a visiting professor, and I was invited to give a lecture, and I gave a lecture to the faculty about ME, CFS, or myalgic encephalomyelitis, chronic fatigue syndrome, and my husband Randy was sitting waiting in the parking lot to drive us home back to Toronto. And Nancy, as we were coming across the parking lot, she said, how would you like to come to work for me? And I said, let's talk.
That's great. So she saved you from all those cruel, harsh Canadian winters.
They're not so bad. In Toronto, we only get a total of 3 feet of snow, so we're very fortunate.
Very good. Well, it's a good thing that she ran into you in the parking lot one more time. Can you give me or give our audience an idea of how many of your patients are dealing with chronic illness?
I would say 100%.
Really?
So the kinds of patients that I saw in Toronto and also here are people who have chronic debilitating illnesses, and they include, in terms of diagnoses, myalgic encephalomyelitis / chronic fatigue syndrome, which we tend to call ME, fibromyalgia, chemical sensitivities or mast cell sensitivity syndrome, and also other fatiguing illnesses such as post-COVID illness, and veterans who have been injured in combat and Gulf War illness veterans. So those are the kinds of people that we're seeing, plus any other really fatiguing illness.
So when a new patient walks into the door, what are the 3 areas that you want to work on right away?
Well, when a patient walks into the room, I like to assess them to see if I can, how they move, what is their ability to sit up, do they have to lay down, how tired they are. So from my perspective, my number one goal is to develop a relationship with the patient who walks in the door. So my number one goal, I think, is to validate the patient's experience. They often have been to 10 to 15 doctors, never really been diagnosed with any illness, and they don't understand that they're not understood. They've often been told they have depression, anxiety, they have ADD, ADHD, but never really put the whole illness together. And I think my most important goal is to validate the patient's experience. And then what I ask them to do is I ask them to basically work with me on what are the top 3 problems that they have, because they usually have a dozen or more. So we can't possibly work on all of them in the first assessment. So we start to work slowly on one at a time. So we often work on fatigue is often their number one problem, sleep, not inability to sleep, having unrefreshed sleep, and cognitive issues is the other thing, which goes along with anxiety and depression. So those are the main areas that I like to start to work on with the patient, if those are their top 3 problems.
Right. So I think one of the differences between our clinic and a lot of places is that idea that we believe and understand the patient, as opposed to a lot of places that think that they're just tired or lazy. And I think that that's one of the things that we work so hard to differentiate ourselves from other clinics.
Absolutely. And I think the validation of the patient is probably the most important thing that I do. And I got into this area over 30 years ago now, and I was classically trained. I'm a hematological pathologist, so I've done a lot of things, and one of them was oncology. And this woman was sent to me, and she didn't have the classic oncology problems. She wasn't leukemic or low or high platelet counts, but she basically, when I walked in the room, it was the end of the day, 5 o'clock, and she was lying on the examination table, and she didn't sit up. And I thought, well, that's odd. So then I spoke with her, and she didn't have the classic oncology things that I was used to seeing at that time. So I said to her, and she didn't have a lot of signs and symptoms, but she was obviously exhausted to the point where she couldn't even sit up to greet me. So I said to her, has anybody ever suggested what you might have? Because the rule of thumb I find helpful is, has anybody else told you what you might have? Because the patients are very clever.
That makes sense, right?
So she said, well, somebody mentioned something about chronic fatigue syndrome. So this is, again, 30 years ago. So I went back to Harrison's, the Bible of Internal Medicine, looked it up, not a word. It wasn't even mentioned. So I came back to her very sheepishly, and I said, and this is pre-computer, pre-internet. So I said to her, again, patients are very clever, would you happen to have an article I could read? Because the medical library in Toronto was 45 minutes away from my office. And she burst into tears. And I said, did I say something to upset you? And she said, you're the first doctor who thinks that there's something physically wrong with me.
Wow.
And it's not all in my head. And I said, I don't know what you have, because I didn't know. I said, I'll certainly be, looking things up. But I said, what I can say to you is you're not normal. There's something really wrong with you. And she burst into tears again. And once the word got around that a hematologist believed in ME, CFS, my phone line lit up, and that's where my practice went to.
So she was the tip of the iceberg.
She was the first. And then after that, my practice shifted, and I allowed it to, because I felt that this was a patient population that was really underserviced and in great need, and I was hoping that I could help these patients.
Mm-hmm. That's interesting. Mm-hmm. In your opinion, what do you think sets the Institute for Neuro-Immune Medicine clinic apart from others?
Well, I think it's a great place because there are physicians who work together on behalf of the patient. So one of the reasons I came from Toronto, because I was a physician working on my own. So it's so nice to have the collaboration of the other clinicians there. And between the bunch of us, we have probably, I'm guessing, about 200 clinical years of experience, which is a marvelous tool that the patients tap into through each of us. Because if we don't know something, then we can talk to somebody who's more experienced in that particular area. So I think that's one of the best things that the clinic has to offer. And we discuss cases. If we have difficulties, and we all do, because these are not known things. So we bring them to the table, and we have rounds to discuss them. And I think that benefits the patients very much so. So they get the best patient care. We also are on the cutting edge of research in this area. We're always reading things. We're always trying to develop new techniques and incorporate them in our practices. And also we have the opportunity, because it is an institute, to do research. So I think it's an opportunity to take research into the clinical field and to be able to develop new tools.
The diagnosis of chronic fatigue syndrome has been elusive for a lot of people. Can you talk a little bit from a hematologist's point of view? What is actually going on in the body when someone is diagnosed with chronic fatigue syndrome? Is it something in the immune system? Is it a virus? Can you explain it to us in a way where we can all understand?
Right. So the diagnosis of chronic fatigue syndrome, or myalgic encephalomyelitis, ME, to say it the short way, is it's a criteria based on clinical symptoms. So it has to be fatigue, post-exertional fatigue with malaise, which are the flu-like symptoms. There has to be a sleeping problem. People have unrefreshed sleep. There may be pain all over the body, not necessarily with swelling and redness, but there's pain that migrates. There often can be autonomic dysfunction. The person has difficulty with their blood pressure, either going too low if they stand up, and they may have a tachycardia syndrome. Their heart may race if they stand up, and they might feel lightheaded. They may have abdominal problems with irritable bowel-like symptoms, and they also may have immune problems. They may get a lot of different viruses repeatedly, or they may be hypervigilant and they hardly get any infections at all. So from a fatiguing viewpoint, the people have difficulty with energy production by their mitochondria. So the mitochondria are the little tiny organelles that sit inside every cell. They are the powerhouses of the cell, and they produce ATP, which is the energy in the body. So just recently there was a conference, and they discovered, because people have been looking for this for years, they discovered an abnormal protein that sits on one of the complexes in the mitochondria, and it gums it up. So that means that ATP is not produced normally by these people. And how this is found is basically you put someone on a bicycle and you compare them to a person who's a couch potato, in other words, someone that's not very fit. If you push them to exercise, after a certain amount of time, the person will be tired, and that's normal. So the first day you do it, they look like the same as a couch potato, and you're asking them to hit it's called their aerobic threshold, when they basically have to stop because it's more than their body can produce. So if you take that same two people, the couch potato and the ME person on the second day, the couch potato does exactly the same thing. The ME person cannot produce the same amount of energy they did in the first place, because they have mitochondrial dysfunction. So, and what happens if people, in terms of if they have fatigue, they need to learn to live within their energy availability, which for some people can be almost normal, and other people, 10% or more, are bedridden. So the key is to live within that available energy so that you slowly start to motivate, and you can slowly start to produce more healthier muscle and more healthier mitochondria. Because what happens is if you push yourself when you have ME, the term is called crashing, which is a reactivation of all of your symptoms. And what happens at the biochemical level is that we all have viruses within our systems. We just do. So when you push yourself and you have ME, you have a reactivation of your own viruses, and this is when you feel terrible. You have flu-like symptoms, headache, and you crash. You go to bed for a day or sometimes weeks. So the key to try to get better is to maintain your energy level, to stay within it without crashing, so you avoid reactivation of your own internal viruses. And they can be things such as Epstein-Barr, which we all know as mono. It could be parvo. It could be a host. It could be herpes simplex. So it could be a host number of these things. It's individual to the person. So the key is to teach the person how to pace themselves, so they stay within their energy envelope without pushing themselves and crashing, but being as mobile as they can to try to increase their muscle energy and also their muscle mass. Because if they can produce a little bit more muscle, the newer muscle has normal mitochondria. So it's a very slippery slope. So I always tell the patients, when you are trying to basically get better, you try to rest throughout the day, and how you do that, pacing is basically asking your body what it needs. And it sounds like such a simple concept, but none of us do it. So basically you have them close their eyes and say, body, in this moment, what do I need? And the answer could be either activity or rest. So if the answer is rest, you say, how many minutes do I need to rest? And then you have them scroll through the 5 times table, 5, 10, 15, whatever. And you have them set the alarm on their cell phone. And they lie down and they rest. And when they get up, the question is, body, in this moment, what do I need? And hopefully it's activity by this time. How many minutes can I go to the kitchen and have something to eat? 5, 10, 15. Set the alarm, and when it goes off, they stop. And they reassess. So by doing this, it teaches the patient how to live within their available energy, how to stop crashing, and how to go from basically being stuck in this crashing cycle and getting worse over time to actually being able to live and have a more productive life and be able to plan. And so you go from basically being a victim of your illness into being victorious, mastering your illness.
I love that. That's great. Victorious over your illness. Mm-hmm. In our clinic, we built our clinical world around an integrative medicine approach, which just seems at home in the College of Osteopathic Medicine, which is very, very much in tune with the whole body medicine. Why were you drawn to work in the College of Osteopathic Medicine?
Well, I had been doing integrative medicine for many, many years, and my introduction to it was through a patient who later on I diagnosed with having multiple chemical sensitivities, or now we would call it mast cell activation syndrome. And this woman had ME, I had no doubt of it, and I did a bunch of blood work, which we always do to rule out everything else that can cause fatigue and all the other symptoms. And she had a very low B12 level, and the hematologist in me was jumping for joy. I went, oh, finally, I can give this lady something that's going to give her a bit of energy. So I injected her in my office with a B12, and she had an anaphylactic reaction in front of my eyes. And I went, oh my. So obviously I treated her, phoned the paramedics, whatnot, and I was absolutely shocked. I thought, how could this happen from a simple B12 injection? So anyway, she refused to go to the hospital, and that was the other outstanding thing, because she knew that the hospitals are filled with chemicals because they do a lot of cleaning, and she would get sicker in the hospital. So I ended up staying in my office till 1 o'clock that morning until she was stable enough to go home with her mother. So after that, I thought, wow, I need to find out what's going on here. So I phoned a friend that at that time was at the Toronto Women's College Hospital, the Environmental Health Clinic, and I said, this is what happened. They said, go read the label on the B12 box. And so I did. And they said, what do you see? The preservative was formaldehyde.
Oh, wow.
So this woman was anaphylactic to formaldehyde. And that was my introduction to chemical sensitivity. So I thought, well, that means that I need to learn something else other than the traditional medical milieu that I knew through the compendium of pharmaceuticals. So that's what basically started my looking into how to support the patients in a different way. So of course, diet was number one. And then I learned about herbs and all the other alternatives such as acupuncture, and then I learned how to do hypnotherapy and cognitive behavioral therapy. So my approach ended up to be a holistic body approach because that's what the patients really needed.
One of the things that I was most impressed by when I first met you in my other role here at the university was how curious you were and how many different kinds of degrees you actually had. And a conversation where you said, if I recall it correctly, that you needed to get a degree in psychology or psychiatry at the time because you had run into a patient that required tools that you didn't have under your tool belt. So that is something that I have found working at the Institute separates the clinicians from most doctors, MDs that you meet, is that curiosity to find things out.
That's right.
And how your reading of this label and this one person's reaction to something that you thought was going to help kind of led you down this whole other path.
Absolutely, because I found that, in Ontario, just as it's in here in Florida, there just aren't enough psychologists to go around. And so I knew of a retired psychiatrist who was doing cognitive behavioral therapy. So I asked him to come in. And so we had basically weekly sessions for 5 years. And he taught me how to do cognitive behavioral therapy. And that worked so well. Then I learned how to do hypnotherapy. And that worked very well because a lot of the patients who have anaphylactic kinds of reactions and are really very anxious really benefit from being their own self-modulating hypnotherapist. So they can learn how to calm themselves down. And it's very helpful because in most people who are sick, they are overstimulated a lot of times. They're in the sort of stress reaction, the fight or flight reaction. And it's natural because no one's believed them for many years. So ideally, it really helps the body to heal if you can teach the person how to develop their own increase in tone in the parasympathetic system, which is the rest and digest autonomic or automatic system in the body. So the more you can tap into that and the more you can help the person to develop that sense of peace and that calmness, it really helps. It helps reduce the amount of adrenaline, the amount of cortisol, and it helps them to heal because this is where the body is in the regenerative state. So that's why I became the hypnotherapist as well, because I found it was very helpful for the patients. Yeah.
So one of the things that I think happens is that not everyone has access, obviously, to the Institute or to the clinicians in the Institute. And you just touched on one thing that people can do on their own, this idea of relaxation or meditation. Can you talk about a couple of other things that people that don't have access to the clinic can do on their own if they find themselves in a chronic state?
Right. So I wrote a book for the patients in grade 6 language. It's called Hope and Help for Chronic Fatigue Syndrome and Fibromyalgia. And I wrote it because there aren't enough clinicians to go around. It's written in everyday language, and it walks you through all of this information. So I'm not necessarily plugging my book, but I just want you to know that there is information out there for you. So the kinds of things that help you are looking at how to relax yourself. For some people, learning to meditate is great. And now there are great apps online that you can tap into. One of them is Calm, and there's several others that are very helpful. You can see YouTube's on video. So all these things just help you to get your heart rate down, get your breathing lowered, and get your brain off being hypervigilant. So that is extremely helpful. If you're up to having enough energy, if you can possibly go out to a yoga class, a stretch kind of yoga class, not what I call the pretzel yoga, but more of the stretch and regenerative yoga where you're lying down and you're stretching, that is very helpful. Walking, if you're up to it, if you can walk 5 to 10 minutes even a day. If you're not up to getting out of your house, start to walk inside your house or inside your apartment building. I call it perimeter walking. So you walk from your bedroom to the kitchen, and then maybe perhaps to another bedroom, to the living room. But you ask yourself, body, in this moment, how many minutes can I walk for? If it's 1, then you do 1 minute. But you gradually can rebuild muscle, and that will help you to gain your functionality back. So if you can't get out of bed, then there are a range of motion exercises that you can do. There are some physiotherapists that come to your house, but if you can't afford that, then go online and look up range of motion exercises. And you start off with perhaps doing 1 or 2 without any weights. So you listen to your body and you slowly improve. And of course, the key of getting better is nutrition. And part of the difficulties for some patients is they're alone and they have no one to cook for them. Right. So if you are in that state, if you can possibly get some help in that area, possibly get some what I call meals on wheels, someone in to deliver some nutritious meals. If not, if you're a big batch cooker, if you can cook some things, freeze them and pull them out one by one, I think that's very helpful, because if you don't have your meals, then you will not have the energy to replenish your body and to heal. Sure. So if you need help with that, there are food banks, and sometimes they do make deliveries. If you are bedridden, then you may need the support of someone to come in to give you a bed bath or to help supervise you while you're in the shower. So all these practical things are essential. And the other thing is that you may need to get, if you have disability benefits and they're cut off, you may need the help of a lawyer to help you fight to get your benefits started or reinstated, because you are legitimately ill, and there are disability lawyers out there who can help you with that.
That's great advice. Looking at this space in general, what do you see as something cutting edge that may or may not exist, that may be down the future, or that we're currently using that people may not know about?
Well, I think we're using the holistic approach with our patients, which I don't think most people know about. So we do like mind, body, spirit, emotions, and I think that's key. Also cutting edge, we tend to use medications that help support the body to heal and detoxify. So we basically recommend supplements or vitamins. And with that, sometimes some patients can tolerate sauna therapies or things like that to help their body detoxify. Or you can go from warm to cool water baths, those kinds of things. So I think those kinds of things are very helpful. We also, for a while, had group classes, which I thought were really great. So you get people together so that they can have the support of the group. So we were doing that for a while, and I think I'd like to return to that because I found that very helpful.
Sure. I think that would be a great idea. Mm-hmm. From your perspective, where do you think we need to be? Where do you see us going in this field in medicine?
Well, I think now that we know that there's a mitochondrial difficulty, it would be lovely to use some of, we have a wonderful computational biology, and that's one thing I didn't speak to. So we have the ability to look at what the problem is and try to solve it from a multitude of different angles, including not only traditional medications, but also herbs and supplements. So wouldn't it be wonderful to look at this new mitochondrial problem to see, is there some sort of a supplement or something that we could figure out what would help to rebuild the mitochondria, and perhaps to do a clinical trial on it to see, if it was worthwhile pursuing. So that's the kind of thing I think would be helpful. And we're also looking at different herbs as well in some of the research. I'm looking at an alternative, which is considered alternative for the treatment of veterans who have mild traumatic brain injury. But it's not just veterans, it's also people who have had multiple car accidents, hockey players, etc. So I think looking at these areas and being able to collect patient data so that we can potentially develop research and see which methods are helping the patients.
Can you talk a little bit about how important it is, the relationship that the Institute has, that the patients, how it's connected to our research? So when you see a patient that comes to the clinic that might have something that is unexpected or something different, how that connects to the clinical research that goes on at the Institute?
Right now, we're currently having a research that's specifically about patients who have long COVID. So I think it's wonderful for the patients who have that problem, who come to the clinic, to be able to tap into that research in particular. There's also research for veterans who have Gulf War illness, to look into certain herbs and to have certain methodologies done in terms of trying to help them. So I think there's all kinds of different. Right now, I have a patient who has severe anxiety. So there is one research project that is to dealing with how to, again, what we were talking about before, how to turn the parasympathetic mode up and the sympathetic mode off. And it's using a system that helps regulate the amygdala in the brain. So they have access to this. Mm-hmm. So as they go through, we can determine if we think that they would be interested in research and try to get them into that to see if we can prove some of these other methodologies to help the patients.
And also they're also then exposed to alternative therapies that they may or may not be exposed to on a regular basis.
Correct.
Dr. Bested, can you share with us maybe some pearls of wisdom, some stories of hope that will be helpful for our listeners to get to a better state of health?
Yes. One story comes into mind, actually a couple. One fellow came to me, he was extremely fatigued. His energy was 3 out of 10. We developed a functional capacity scale that helps patients to determine if they have normal energy or not. So normal energy would be considered 9 to 10 out of 10. This fellow became to me about a 3 out of 10, which meant he was able to kind of get up to go to the bathroom, have a bath, and maybe be up for a meal, but that was about it. He was pretty disabled and unable to work for a couple of years. So I worked with him. He understood the importance of pacing and stopping crashing. So with all my patients, I asked them to fill out these activity logs, which is really a daily planner. And you just write down one word of what you're doing and what your energy level is, 0 to 10. So over time, he went from a 3, and then he was up to a 5, and within 3 years, he was up to an 8. And by the time he basically, at that point in time, he started to work part-time from home, and he was able to increase his energy still, and he got to go back to work full-time.
Wow, that's amazing.
I think it just shows people that, this may not happen for each and every person, but certainly this man, it did happen. And what I say to patients is, if you have a range of energy, say between 3 to 5 out of 10, 3 being the lower number and 5 being the upper range, or maybe walk for 20 minutes, I say to them, wouldn't you rather be a 5? Of course, they say, well, of course, who wouldn't want to be a 5? So I say, well, and they say, well, how do I get there? I say, you stop crashing. So by listening to your body and taking the crash periods out, your body develops more and more 5s and less 3s. And then the occasional 6 pokes its head up. And then a few more 6s. And this is how you get the change in direction and you start your body healing.
So for the people that are not able to come to the Institute and have you, take care of them and diagnose them, what should they say to their doctor if they live in the middle of the country somewhere where this institute is not accessible to them, but they know that they may have something that's undiagnosed? What would you say to people are the most important points to get across?
Well, I think they're probably more knowledgeable than their doctors, which is a fact. I started teaching about myalgic encephalomyelitis in KPCOM about 3 years ago. And at the time, we were only the second school that was a DO school that was teaching about it. So I'd ask them to make allowances for their doctors and try to work alongside them to educate them. There are certainly really good references. We have them on our website. Look up how to diagnose ME and the criteria. And then I would just suggest that they try to listen to their bodies and try to stop crashing. I think that's the most important thing. yes, there are other treatments that can be specific, but if they can do that one thing, it will make a huge difference in their ability to have energy, have more energy this year than last year. And by doing that, they eventually will climb out of the deep hole that they're in. And the other thing I just want to point out is as people get better, so for example, if people come to me with an energy level of 3 to 4, and then they gradually improve, which they do most of the time, to 5 to 6 out of 10. What I notice is that at that level, so they've gone from a survival mode, which is about a 3 out of 10, to wow, I've got some life at 5 or 6. What I notice is often patients at that level start to be aware of how sick they are. And sometimes they think they're depressed. And I would say they have depressed symptoms, but what I think is happening with them is they are coming to the terms that they understand how sick they've been. Right. So at that point in time, I would urge people to go for some grief counseling because they need to grieve the loss of the life they used to have. They had a full-time job, they could party, they could do whatever they like, but now they're restricted compared to their old life. So I would ask them to compare their better energy level, not to their old life, but to where they started off with at the beginning when they were homebound or bedridden. But they might need some professional help to grieve the loss of the life they had. And that's perfectly normal. That's part of getting better.
And I would imagine that after feeling so ill for so long, that more positive mindset has to make a difference in your recovery to some extent.
And that's where learning or going to a therapist who does something similar to cognitive behavioral therapy, which really is just listening to your thoughts. So, for example, if the person's having a day where they're crashing in bed, they can say this particular thing. They can say, "Oh, here I go again. You know, I'm sick. I'm never going to get better. It's my life is over." So that's a pretty horrendous thing to say to yourself, and it makes you feel a lot worse. Yeah. So that's called catastrophizing. So instead, you can learn to substitute, your thoughts with, yes, I'm having a bad day today, but in the past, I have felt better after I've rested, and tomorrow I will probably feel better. Right. So you end up trying to have hope for tomorrow because most of the time, tomorrow is a better day.
That's a good lesson to keep in mind for anybody, probably.
That's
not
right.
just people with chronic fatigue syndrome.
Yeah. When I used to do cognitive behavioral therapy, we had a little bear, and it was so cute. On it was a little heart, and the heart, it said, whoever did the work with me that day got the bear. So it said on it, yesterday is history, tomorrow is a mystery, but today is the gift. It is the present. That's right. So that's what cognitive behavioral therapy, and that's why learning to listen to your body in the moment, it keeps you present-centered, so you have a much better life.
Mm-hmm. Good advice. What are you the most proud of, and what are you the most hopeful for?
Well, I think I'm the most proud of being able to listen to my patients because my patients are the ones who inspire me to continue. And having that validation from them helps me to help them more. So I think I'm proud of my relationships with my patients. And lately, I've just started to do research in veterans, which is the treatment of veterans who have post-traumatic brain injury or post-concussion syndrome with hyperbaric oxygen therapy, and it's going extremely well. So I think that's been a real bonus coming to NSU is the ability to open a whole new door that I had no idea existed before I came here.
Well, I want to thank you so much for being here today. I think you've given all of us a little bit of hope for sure and some new ways of looking at our days when we're all happy and healthy and there are other people that are dealing with a lot more. So we will have you back to talk more about your research. And once again, we really appreciate your time today.
It's been my pleasure.
Thank you.